We now move on to the next section of the agenda on operational performance, and the first item, item 8 on the agenda, is the NHS England Corporate and NHS Performance Report. Matthew and Karen, I think, will share this, but Matthew, may I please invite you to kick us off?
Thank you very much, Malcolm. It's a pleasure to be here for my first meeting. It's even more exciting than I expected.
We haven't finished yet.
So let me talk about NHS performance. We are early in the financial year, so the story is still emerging. But perhaps just to set it in context, demand remains high in the NHS and is continuing to increase, which is why some of what we've been talking about earlier is so important to the work that Arvind and Ros are leading on investing in primary care, the work that Ian's team are leading on new models of care, and the other work that's going on enhancing ambulance services and 111, the close work with social care and the work being done with technology to try and enhance individuals' ability to support themselves is all critical to how we manage an NHS going forwards. And I've had the pleasure of doing 44 STP reviews with Simon over the last few weeks where we've been digging into that and how you create the transformation to make the NHS sustainable going forward. But last week's reset also reflected the renewed focus on what needs to be done this year in order to achieve our promises to patients and the public, and so we're now in a position where trusts have specific trajectories in order to deliver those objectives at individual organisation level, and in that context we've dropped the financial penalties that we were applying to individual targets and are supporting NHSI in their work to help the struggling providers get to the level that they need to. So there is a wide range of work going on at the moment to hit the performance targets. And I think probably should just touch on a couple of areas that are in the report. A&E, from what we can tell from the data in the first couple of months of the year, growth in emergency admissions is about on track with what we expected. Some areas are seeing some spikes in emergency attendances, which we need to establish whether something's actually happening or whether that's just the natural bouncing up and down of data over time. Performance is improved on April, but is still below the target level that we would expect. So we have just launched with NHS Improvement the A&E Improvement Plan, which will be guided by regional A&E delivery boards that are being created as we speak, and we'll be focusing on the 5 things that we know work, and we will be expecting all health systems to put these things in place. Primary and ambulatory care screening in A&E departments so that patients get the right care quickly, and if they don't need to be in an A&E department, we can move them onto the right setting. Increasing the proportion of 111 calls that are handled by a clinician to take pressure off the ambulance services of A&E departments and of GPs if we can close those calls down in one call. Implementing the ambulance response programme, implementing what we know as best practice in every hospital for managing the flow of patients through hospital. It's still, as an ex-hospital chief operating officer and chief executive, it still takes me by surprise the huge variation in performance you'll see with organisations who are spending the same resources on basically managing the same sorts of patients, and some are doing it brilliantly and others are doing the opposite of brilliantly. So we do need to make sure that everybody is applying best practice, and NHSI are very focused on that, and ensuring that discharging best practice is in place, so that as we work in partnership with social care, we don't have patients unnecessarily in hospital to neither our benefit nor theirs. They should be receiving their care in the right location. So a lot of work going on to drive A&E performance and improve the care that people receive. And as has been worth noting, as has I think been said elsewhere, the delayed transfers of care issue is an increasingly significant one for the NHS, rising generally, but rising particularly amongst patients who are waiting for social care packages. And it's important. We are a partnership with social care in delivering this, and if they are unable to provide the set of services that patients need, then patients end up in NHS facilities rather than being cared for in more appropriate locations. So the other area I'd like to touch on just briefly is around RTT waiting times. Again, we're seeing improvement on April, just missed by a fraction of a percentage the target, but not where we would want to be at this point in the year. So a huge amount of work that needs to be done, and a series of actions going on, both outside of hospital, trying to make sure that GPs have the right set of services to refer to, and we're not getting an unnecessary flow of referrals into hospitals, but also within hospitals targeting, for instance, a huge variation in follow-up ratios of between hospitals. So hundreds of thousands of appointments, variation between best hospitals in terms of their new to follow-up ratios versus the others, which would free up an enormous amount of capacity for new referrals if we could get everybody to the standard of the upper quartile. And so we are working with NHSI on a series of specific local actions everywhere across the country in order to raise that performance. So I'd say it's early in the year. We're seeing improvements in many areas, but there's still a lot of work to do, and we're very focused now on the move from having a plan to seeing execution of that plan at ground level.
Thank you. May I invite any comments on that before we turn to Karen's part of the report? Well, could we just focus on the issue that you've highlighted, which is the variation in performance? And you quite rightly observe in relation to patient flow that there's a big variation between institutions that are using the same resources to achieve the same ends with basically the same sort of patient mix. And the same will be true of A&E, RTT, etc. We all know that hospitals are quite complex organisms and that everyone is different, but it's still puzzling that after all of these years when we've been going on steadily on this problem, that we still have this extraordinary variation in performance. And one thing that always strikes me when we get the data coming to the board is that although we take aggregate data for the whole of England, it disguises the fact that there are great variations between different hospital trusts, and some poor performances and some of them bring down the national average. So how satisfied are you that the steps that you've just outlined are going to help us to collectivise experience, to provide the mentorship and to provide the exchange of intelligence about how to run these specific services at the highest level across the whole of the provision?
Well, I think NHSI are gearing up to be able to do that, and we're working closely with them. I'd say in Jim Mackey they're being led by the right guy. His organisation has continued to be a national high performer, even whilst he's been down working with us nationally, and that's a very fine example of an organisation that just does it. And you can find these all over the country. So if you go to Luton, you'll find it being done. If you go to Surrey and Sussex Hospital, you see it being done routinely month in, month out. So I think this will be a high priority for us working with NHSI to make sure the systems around hospitals, from our point of view, are running optimally, and we're taking the best practice and applying it everywhere. And then once you get within hospitals, NHSI will be focusing on that performance. I think we know what works now. We know what good triage in A&E looks like. We know what good bed management looks like. We know what good preparation for discharge looks like. We know what good relationships with social care looks like. We just now we need to make it happen flawlessly.
So it is, as we so often observe, a question of leadership in each of these institutions to instill the culture change that will bring about the performance improvements.
I think it's very much part of leadership. If you go in, if you talk to any of those successful organisations, their chief executive will, the first phone call they make as they're driving into work in the morning is asking what the state of the hospital is, and the last call they make as they go home in the evening is checking the state of the hospital, and at any moment during the day they know what's going on. And that ownership driven by the lead clinicians throughout the organisation and owned by the executive, not behaving like victims of the circumstances that they find themselves, but actually driving performance. It's really hard. I mean, running hospitals is really hard.
Yes.
And we have lots of new folks coming in doing it for the first time, and we need to make sure we're supporting them and training them and getting what we know works spread and supported across the system.
I think this is absolutely top priority for us, isn't it? Working in the closest possible partnership with NHS Improvement, but it is something where the decline in constitution standards of observance in some of these issues has been marked in recent years, and it's very easy to assume that the straitened financial circumstances will lead to further deterioration, when in fact we know that the remedy is there. And that we can bring about the improvement that we need to bring it back up to full compliance.
Yes, and we must, it's the both and that Jane just talked about. We both have to get this year right, and we have to do the things that need to be in place for next year and the year after and the year after, so that we don't stumble from one fire drill to the next as we trying to deal with it on a crisis by crisis basis, rather than getting into this is a managed system, because the public expect us to deliver a managed system, not a series of incidents.
Yes, and our role is to support the improvement.
Yes, absolutely.
Other questions for Matthew?
No, then perhaps Karen, maybe we turn to you.
Yes, thank you, Malcolm. This report is really about the assurance of our delivery against the national programmes that we're running, and we obviously continue to assure those, as you would expect. Indeed, we've actually discussed a number of these programmes over the course of today and in our previous meeting yesterday as well. So I wasn't going to go into a huge amount of detail. The real focus of our assurance at the moment is on readiness and capability and capacity for delivery and implementation, because that's what we really need to step our game up on this year. And Simon referred to the mental health implementation plan, for example, as being a very good example of that, and Jane's talked about learning disabilities and how that's happening on the ground as well. And there is more to do in some of the programmes to really step up their capability. And the other thing is 3-year delivery plans. We really need to see plans for the next 3 years, not just on an annual basis, and that's a subject of considerable further work. The only area I was going to pick out was the information and technology portfolio, because a huge amount of work has been done recently on reframing and reshaping that portfolio. Matthew has now taken that responsibility over, but the key objective of that work was to align it and link it much more closely with the 5-year forward view and the work that needs to happen in delivery, and to ensure that we are allocating our priorities appropriately into that programme. In that context, one of the programmes that is highlighted as being red, widening digital participation, is an area where some progress has been made recently in terms of agreeing the funding for that programme, and we expect that to move out of red very quickly. So that was all I was going to say.
Thank you, Karen. Anything for Karen? No? Great. Thank you very much, Matthew and Karen.